Dear students, in this part of the clinical snippet, we will cover a complex topic, though not that complex, but it is perceived as a very complex topic, and it is localization of stroke syndromes. Clinical features of stroke and how we localize the clinical picture of a particular stroke to a particular arterial territory. This will be the clinical snippet. We will be dividing into two parts. In the first part, after the introduction, we will try to complete and compile the stroke syndromes due to the anterior circulation, and in the second video we will try to compile the stroke syndromes due to posterior circulation. Before that, another thing I want to tell you that we will keep things very simple mathematical diagrams rather than again entering into the complexity of the neuroanatomy and each and every branch. For undergraduate and postgraduate, we will try to keep things simple with engineering drawings, simple algorithms and simple diagrams, and we will try to understand the stroke syndromes. It will be enough if you just go through these and practice the diagrams. Obviously, also in clinical situation when you will be dealing with cases of strokes, it will be easy to diagnose. So before आगे बढ़ने से पहले, let us first know the circulation of the brain. To understand the circulation of the brain, we have to keep two things in mind. The brain is supplied by a lot of arteries. There is a circulation, communicating circulation, branch circulation, but the basic nuance of the circulation description is two main distribution territory they supply the brain. As I told, one is an anterior circulation, second is the posterior circulation. When I talk of the anterior circulation, we are talking of internal carotid artery and its branches. If you see this diagram, this is the internal carotid artery, and the internal carotid artery is divided into two. One is a continuation as the middle cerebral artery, and another branch coming out, that is the anterior cerebral artery. So internal carotid artery is divided into middle cerebral artery and anterior cerebral artery. There is a small artery here which is coming out from the internal carotid, which is the ophthalmic artery, which is supplying the retina through the central retinal artery. Now, when I talk of this is the anterior circulation, the internal carotid, middle cerebral plus anterior cerebral grossly is supplying which part of the brain? ब्रेन का कौन से पार्ट को एंटीरियर सर्कुलेशन सप्लाई करता है, वो आगे मैं क्लियर करूंगा जब हम मिडिल सेरेब्रल टेरिटरी, एंटीरियर सेरेब्रल टेरिटरी में इंडिविजुअली जाएंगे. बट at this point of time, let us understand this is totally dedicated to the cortex, frontal lobe, parietal lobe, major part of the lateral surface of the brain and the medial surface of the brain. Okay, and this is the second territory, ये वाला part, that is known as the vertebrobasilar territory or the posterior circulation, which is supplying the brain. Now, when I talk about the posterior circulation, how it is arising? Two vertebral arteries. Now, this vertebral arteries, right and left. The right vertebral artery is arising from the right brachiocephalic trunk, which is a branch of aorta, from the right subclavian, and the left vertebral artery is directly arising from the left subclavian, which is directly arising from the arch of aorta. So these are the vertebral arteries. They come and they unite to form a basilar artery. This is the basilar artery. They unite to form this artery, which is the basilar artery. Now the basilar artery then again divides into two posterior cerebral arteries. So middle cerebral artery, anterior circulation, posterior cerebral arteries are posterior circulation. It is a part of vertebrovascular artery. Now there are other branches also. This vertebral artery is giving a branch which is known as posterior inferior cerebellar artery. नाम से ही समझ में आएगा. Now once it is formed the basilar artery, at the root of the formation of basilar artery there is another artery which is a branch which is known as anterior inferior cerebellar artery. Then the basilar artery gives rise to small perforators which are known as pontine paramedian perforator branches. which are supplying mainly to the pons and some part of the cerebellum. Now there is another artery dedicated to cerebellum after the pontine branches is the superior cerebellar artery. Now it is divided into two posterior cerebral arteries. Now these two divisions, anterior circulation, posterior circulation, the nature has again given protection. These two circulations are not separate. They are also communicating with some communicating arteries. This is an emergency situation. If there is something catastrophe happening here, carotid can supply. If there is some catastrophe happening here, another communicating artery can be supplied. What is those communicating artery? From the internal carotid artery, a artery which is communicating with the posterior cerebral artery, this is known as the posterior communicating artery. That is joining from the internal carotid to the posterior cerebral artery. Now, another communicating artery is the anterior communicating artery, which is communicating between the two anterior cerebral arteries. Because anything problem, if at all occurs here, collaterals can support through the posterior communicating, they can help the anterior circulation. If something is going wrong in the posterior circulation, nature tries to compensate by the posterior communicating artery. If anything happens to this segment or this part, nature is also supplying this route, this route, this route. That is the anterior communicating artery. So this is the basic of the circulation of brain. Now there is another term which is known as the circle of Willis. If we see, is it looking like a circle? No, not at all. It is not looking like a circle. But if you concentrate, this part is looking like a circle. This is the circle at the base of brain. That is why it is known as the circle of Willis. So circle of Willis means internal carotid artery, posterior communicating artery, posterior cerebral arteries, posterior communicating artery, internal carotid artery, anterior cerebral artery, anterior communicating artery. These are the segments of the whole blood supply of the brain, which is creating a circle at the base of the brain, and it is known as circle of Willis. Okay, so after this brief description, when I told that the anterior circulation is dedicated to the cortex, basal ganglia, subcortical area, all those things. Cortex में primary, which are the cortex I told? Frontal lobe, parietal lobe, some part of the temporal lobe. But the vertebrovascular system is principally dedicated to the brain stem, cerebellum, and of course cortex, that is the occipital lobe, and some part of the medial temporal lobe. So the vertebrovascular system is dedicated to the occipital lobe, some part of the medial aspect of the temporal lobe, inside part of the temporal lobe, brain stem, that includes midbrain, pons, medulla, and cerebellum. This part is dedicated to this. This part is dedicated to frontal lobe, parietal lobe, subcortical areas, basal ganglia, all those things. So now we will be delving in details into different territories of strokes. So now starting with the anterior circulation stroke after the introduction, we will just start with if there is a occlusion in the internal carotid artery stem. Internal carotid artery stem. So as we know, the internal carotid artery gives branches. One is a continuation as the middle cerebral artery and the anterior cerebral artery. The internal carotid artery mainly divides into middle cerebral artery and anterior cerebral artery. In briefly, I have already told you, the middle cerebral artery supplies most of the lateral part of the cortex, parietal lobe, subcortical area, corona radiata, basal ganglia, and all those things. The superior temporal gyrus, inferior parietal lobule, both the Broca's area and Wernicke's area, all the important part they are supplied by the middle cerebral artery. And the anterior cerebral artery, we have already discussed, a motor strip, superior, lateral and medial aspect of a motor strip is supplied by the anterior cerebral artery. Now another interesting thing here is the internal carotid artery also gives a artery which is known as ophthalmic artery, which supplies the retina through the central retinal artery. So first we will discuss, it is simple, when we go into anterior cerebral artery territory stroke syndromes and middle cerebral artery stroke syndromes, the answer actually lies there, because all the clinical features will be, if it is internal carotid, mathematically applying, stem is gone, the clinical presentation will be MCA clinical features plus ACA clinical features, which later on we will be clarifying when we will go in the MCA territory stroke. In details we will discuss. Anterior cerebral artery stroke we will detailing discuss. So the formula will be IC block is equal to clinical presentation of MCA block plus ACA block. Okay, यहाँ पे MCA ACA में जाने से पहले विविध डिस्कशन हुआ है, बट अभी मैं सिर्फ नाम ले रहा हूँ, आप लोग कान में घुसे एक बार, फिर जब समझेंगे तो समझते जाएंगे. सिर्फ कान में घुसे कैसे प्रेजेंटेशन कर सकता है. अगर टोटल इंटरनल कैरोटिड आर्टरी स्टेम ऑक्लूजन हो गया तो देयर विल बी सडन हेमीप्लेजिया, कॉन्ट्रालैटरल हेमीप्लेजिया, कॉन्ट्रालैटरल हेमी एनेस्थेसिया, कॉन्ट्रालैटरल होमोनिमस हेमियानोपिया, इप्सिलैटरल ग्रेज प्रेफरेंस, जहां पे इन्फाक्ट हुआ है दोनों आंख उधर की तरफ देखेंगे, ऑपोजिट साइड में पूरा हेमीप्लेजिया रहेगा. ओके, इफ डोमिनेंट हेमिस्फीयर इज इन्वॉल्व्ड, there will be global aphasia, conduction aphasia, so speech problems will come in. There will be ideational apraxia, ideomotor apraxia, and if the non-dominant hemisphere will be involved, there will be characteristic features like sensory hemi-neglect, लेफ्ट साइड को नेग्लेक्ट करेगा. ये सब समझा है, आगे हम समझेंगे. तो हेमी नेग्लेक्ट, ये सब क्लिनिकल फीचर्स आएगी. अप्रोसोडिया, स्पीच एरिया, अगर नॉन डोमिनेंट हेमिस्फीयर के स्पीच एरिया इन्वॉल्व हो जाता है तो एक कंडीशन होती है जिसका नाम है अप्रोसोडिया. उसमें क्या होता है, जैसे हम बातें करते हैं, क्वेश्चन किसी को पूछा मैंने, व्हाट इज योर नेम, क्वेश्चन मार्क सामने आता है, तो मैं वैसे बोल रहा हूं, अरे बाप रे क्या हो गया, एक्सक्लामेटरी मार्क, तो ये सब हट जाएगा. सिर्फ देयर विल बी मोनोटोनस टोन, सिर्फ मोनोटोन में बात करेगा, क्या हो गया, क्या नाम है तुम्हारा, ऐसा बात करेगा. तो that is known as aprosodia. Sensory hemi-neglect. Then two types of apraxia can occur in non-dominant hemisphere. That is constructional apraxia, dressing apraxia. पहन नहीं पाएगा शर्ट पैंट वगैरह. कैसे सब आगे we will discuss all these things, but to just enter your ears these terminologies. And अगर anterior cerebral artery territory stroke होता है तो वही hemiplegia होगा. Leg will be more involved because the leg area is in the distribution of anterior territory circuit. There will be urinary incontinence because the frontal lobe controls the urinary behavior of urinary passing urine. वो चला जाएगा, urinary incontinence हो जाएगा. एबुलिया हो जाएगा. What is एबुलिया? That is profound weakness, or that is a profound weakness in initiating any activity. Supremely lazy type हो जाएगा. Difficulty in initiating any activity. Very slowly काम करेगा. There will be mixed picture of all these things if there is a stem occlusion. खत्म. ये हम बाद में विविडली डिस्क्राइब करने वाले हैं. सेकेंड कैरेक्टरिस्टिक डिस्क्रिप्शन यहां पे आता है, क्योंकि दिस इज द सिग्नेचर. ये अगर है तो इंटरनल कैरोटिड आर्टरी ही है. एंड व्हाट इज दिस, इफ देयर इज ए ऑक्लूजन ऑफ द ऑप्थेल्मिक आर्टरी. एंड यूजुअली the patient typically presents with this ophthalmic artery occlusion in form of recurrent transient ischemic attacks. अगर थ्रोम्बोसिस है कैरोटिड आर्टरी में और वो थ्रोम्बस टूटता है, recurrent small emboli first enter the ophthalmic artery and the patient presents with a classical feature because of retinal ischemia, intermittent retinal ischemia, amaurosis fugax. Amaurosis fugax. This is hallmark. How the patient gives history? On the site of ophthalmic artery inclusion or the ophthalmic artery recurrent emboli, the patient will complain of there is sudden onset of blurring of vision on one eye. And sometimes very classically the patient will describe there is a shade of darkness. There is a shade of darkness in the visual field. बोलेगा एक darkness shade suddenly ऊपर से नीचे आके ब्लाइंड कर दिया, फिर अपने आप क्लियर भी हो गया. शेड विल कम, डार्क शेड कम्स डाउन लाइक दिस इन द विजुअल फील्ड, फिर अपने आप क्लियर भी हो रहा है. समटाइम्स ही कैन से दैट सडनली अपर हाफ ऑफ द विजुअल फील्ड गायब हो गई, फिर आ गया, या तो सडनली लोअर हाफ ऑफ द विजुअल फील्ड हॉरिजॉन्टल नेवर वर्टिकल, हॉरिजॉन्टल गायब हो गया, फिर आ गया। अगर ऐसा है तो इट इज रेटिनल आर्टरी एम्बोलाई, मे बी द सोर्स इज कैरोटिड, and before going for a catastrophic stem stroke, later on the patient is going to present with MCA plus ACA territory. These are the heralding signs, that is amaurosis fugax, site of lesion is internal capsule. Immediately स्टेथो निकालो, कैरोटिड आर्टरी पे लगाओ स्टेथो और देखो कोई ब्रूई है क्या, and that bruit fades into the diastole. That is the initial phase of occlusion हो रहा है, धीरे धीरे thrombotic occlusion हो रहा है, क्योंकि अगर लेट हो गया severe stenosis में the bruit also disappears. So there is an important clinical sign, auscultation of the carotid artery. That is very important in all stroke patients, auscultation in carotid artery. Now one of the rarest manifestations of the internal carotid artery territory stroke is one of the rarest phenomena, which is known as, I told, the fetal posterior cerebral artery. Look at this diagram. Vertebral arteries, basilar artery. Basilar artery should have been divided into two, this side normal, this side abnormal. Posterior cerebral artery should have been come like this on this side, and as we know the posterior cerebral artery is going like this, and from the internal carotid artery, middle cerebral artery, anterior cerebral artery, and the internal carotid artery gives up the communicating branch with the posterior cerebral artery, that is the posterior communicating artery. अब ये जो posterior cerebral artery है, posterior communicating junction ये है, इस सेगमेंट को बोलते हैं P1 सेगमेंट ऑफ द पोस्टीरियर कम्युनिकेटिंग आर्टरी, पोस्टीरियर सेरेब्रल आर्टरी. दिस इज द P2 सेगमेंट ऑफ द पोस्टीरियर सेरेब्रल आर्टरी. ये जो P2 सेगमेंट है दैट सप्लाइज द ऑक्सीपिटल लोब एंड मेडियल पार्ट ऑफ द टेम्पोरल लोब. ऑक्सीपिटल लोब, मेडियल पार्ट ऑफ टेम्पोरल लोब को P2 सेगमेंट सप्लाई करता है. अनफॉर्चुनेटली किसी आदमी में ऐसा रहता है कि पोस्टीरियर सेरेब्रल आर्टरी इधर है ही नहीं, इट इज आर्टराइटिक, ये है ही नहीं, पोस्टीरियर सेरेब्रल आर्टरी यहाँ है नहीं. तो ये कहाँ गया है, कैसा है? इट इज अराइजिंग डायरेक्टली एज ए पोस्टीरियर कम्युनिकेटिंग आर्टरी एंड पोस्टीरियर सेरेब्रल आर्टरी इज डायरेक्टली अराइजिंग फ्रॉम द इंटरनल कैरोटिड आर्टरी. फ्रॉम द इंटरनल कैरोटिड आर्टरी मतलब इंटरनल कैरोटिड आर्टरी यहाँ 3 ब्रांच दे रहा है, मिडिल सेरेब्रल दे रहा है, एंटीरियर सेरेब्रल आर्टरी दे रहा है, और क्योंकि उधर का पोस्टीरियर सेरेब्रल उधर से बना ही नहीं, बैसिलर आर्टरी से बना ही नहीं, तो यहाँ पे उसने पोस्टीरियर सेरेब्रल आर्टरी भी दिया है, एज इफ इट इज अ पोस्टीरियर कम्युनिकेटिंग, देन द पोस्टीरियर सेरेब्रल आर्टरी सप्लाइंग द ऑक्सीपिटल कॉर्टेक्स. तो ऐसे पेशेंट्स में अपार्ट फ्रॉम MCA ACA you will get clinical features of P2 segment of the posterior cerebral artery territory. और एक posterior cerebral artery territory segment का प्रॉब्लम आ सकती है. वो क्या होगा जब हम posterior cerebral artery डिस्कस करेंगे तो डिस्कस करेंगे, लेकिन सिर्फ नाम सुनने के लिए there can be homonymous hemianopia without macular sparing, contralateral homonymous hemianopia हो जाएगा क्योंकि macula is supplied by the middle cerebral artery. There can be color anomia, कलर नहीं पहचान पाएगा, visual hallucinations, tunnel vision, sudden disappearance of the focus in the peripheral visual fields, okay, alexia without agraphia, एक specific situation जो होता है, जो स्प्लेनियम ऑफ द कॉर्पस कैलोजम उसी एरिया में आता है, इसलिए स्प्लेनियम ऑफ द कॉर्पस कैलोजम हो जाता है, तो एलेक्सिया होगा, पढ़ नहीं पाएगा लेकिन लिख सकता है, एलेक्सिया विदाउट एग्राफिया, ये सब हो सकता है. सडन मेमोरी लॉस भी हो सकती है, ट्रांजिएंट ग्लोबल एमनेसिया, क्योंकि वहां पे हिपोकैम्पस मेडियल टेम्पोरल लोब का पार्ट है, तो अगर सडन हिपोकैम्पस इंफैक्ट हुआ, ऑक्लूजन हुआ, तो ट्रांजिएंट ग्लोबल एमनेसिया हो जाएगा. बट रिमेंबर द वर्ड ट्रांजिएंट कोट अनकोट, क्योंकि मेमोरी इज बायलैटरली रिप्रेजेंटेड, तो बाद में वो एमनेसिया ठीक भी हो जाता है. तो दीज आर द क्लिनिकल फीचर्स ऑफ पोस्टीरियर सर्कुलेशन स्ट्रोक, पोस्टीरियर सेरेब्रल आर्टरी. अभी सिर्फ नाम बताया आपको, तो ये हो सकता है अगर एक ही फीटल पोस्टीरियर सर्कुलेशन है, फीटल पोस्टीरियर सेरेब्रल आर्टरी इंटरनल कैरोटिड. So this completes the internal carotid artery. जहां आपने इंटरनल कैरोटिड आर्टरी के बारे में बताया. रिमेंबर कंक्लूडिंग amaurosis fugax, बाकी तो क्लिनिकल प्रेजेंटेशन ACMC का रहेगा. नाउ वी विल स्टार्ट विद द ACA टेरिटरी. So now let's delve into the stroke syndromes that will occur due to anterior cerebral artery involvement. So first let us know in a conventional diagram about the anterior cerebral artery and its anatomy a little bit. As we know that this was the internal carotid artery, circle of Willis में हमने देख लिया. Internal carotid artery से अपना continuation हो गया middle cerebral artery. And now from internal carotid artery से bifurcation होके internal carotid artery से ये middle cerebral artery. Now this is the anterior cerebral artery. And the anterior cerebral artery is going like this from the both internal carotid arteries bifurcation and middle cerebral artery, second branch anterior cerebral artery is going up like this. And we also know that the two anterior cerebral arteries are communicated by the anterior communicating artery. In this diagram, what I am wanting to say is, first we will divide the anterior cerebral artery into two parts. They have other parts, but for our focused discussion, don't worry about the other parts. A1 segment and A2 segment. A1 segment is from the proximal part of the anterior cerebral artery, which is arising from the internal carotid artery and up to the anterior communicating artery. This segment is known as the pre-communal segment of anterior cerebral artery or the A1 segment. And from the after the anterior communicating artery, the rest of the part of the anterior cerebral artery is known as the post-communal segment or the A2 segment. Later on, this post-communal segments winds around the cortex in the lateral surface like this, as we have seen in the diagram. This is in this diagram the lateral surface, and it is showing the territorial distribution of anterior cerebral artery. This is the area which is supplied by the anterior cerebral artery, and this is the medial most part of the temporal lobe, some aspect of the temporal lobe that is supplied by the anterior cerebral artery. So this A2 segment now goes in this diagram sagittally like this. Like this. Okay, let me draw it. It will go like this. Supplying, giving its branches. This part we need not be so much focused about. We have to remember A1 and A2. Further, this has been also divided into A3, A4, A5. We are needless to discuss all those things whenever anterior cerebral territory, because there is no statistical or there is no significant clinical presentation of bit or plus minus. There is nothing called A3 segment occlusion, A4 segment. That doesn't happen. The main clinical feature is if there is a A2 segment occlusion or there is a complete total occlusion at the stem. Occlusion can occur here, complete occlusion. Or else there can be occlusion here, that is in the post-communal, that is the A2 segment occlusion here. Or here is the another part. When I drew the A1 segment, in the A1 segment also there are perforators coming out. There are small perforating branches coming out. Out of the perforating branches, there is one interesting branch which is the largest perforator of anterior cerebral artery. And that largest perforator is known as the recurrent artery of Hübner. So there is a recurrent artery of Hübner which is a perforating branch. It is the largest perforator. So this is in general the anterior cerebral divisions and what are the important localization of the various arteries. Now if I translate into that picture into this is showing the areas of the brain where the anterior cerebral artery is supplying. I have already told you a strip in the frontal and parietal up to the frontoparietal strip. All this is middle cerebral artery. We already know that this is occipital lobe, posterior cerebral artery, and this is also posterior cerebral artery, the medial temporal lobe. But the lateral most of the inner outermost part of the temporal lobe is also supplied by the anterior cerebral artery. When I talk this, I am talking about the perforators. This is in this diagram, in the coronal diagram. If you translate these two into the coronal diagram, here the internal carotid artery, middle cerebral artery, anterior cerebral artery, anterior communicating artery, In the A1 segment, that is the pre-communal segment, these are the perforators. This is the recurrent artery of Hubner, and as you see, these perforators, they are also supplying which areas? Anterior limb of internal capsule, inferior part of the head of the caudate nucleus, anterior perforate substance. This is the anterior perforate substance. It looks like this. It is the area of anterior perforate substance. Some are also supplying the amygdala and the anterior hypothalamus. This part is this part. These are the perforators which are supplying these areas. And now in the A2 segment, that is the post-communal segment, it is supplying the motor strip, most importantly here motor, sensory, and this part leg area, and another important part here which is I have drawn here is the paracentral lobule which controls the bladder. Paracentral lobule. So now we discuss the stroke syndromes. कहाँ पे obstruction हुआ तो क्या usual presentation रहेगा in anterior cerebral artery territory stroke. First, if there is an occlusion number 1 in the A2 segment, that is the distal segment, A2 segment, there is an occlusion. What will be the clinical presentations? And there is no well-developed collateral, and that is the occlusion in the peripheral post-communal A2 segment. So basically, the frontal lobe, the cortical part which is supplied by the anterior cerebral artery will be destroyed. So the clinical presentations will be 1. Contralateral hemiplegia, but the legs will be predominantly involved. Arm weakness will be less. Predominant involvement of the legs. There will be a pure motor hemiplegia with more involvement of the leg because the leg area is situated. We have already shown you that is supplied by the anterior cerebral artery. So leg will be more involved. 2. Hemianesthesia. So in the weak area, that is the paralytic area, there will be loss of pain, temperature, position, vibration, proprioception, all will be lost. So there will be anesthesia also, hemianesthesia. Again, leg will be affected more. Leg में वो sensations सब चले जाएंगे. 3. Urinary incontinence. Because of the involvement of the paracentral lobule, leg area, paracentral lobule, there is loss of bladder control. So there will be loss of cortical bladder control. What will happen here is, usually the cortex inhibits the local reflex, spinal reflex. Say for example, I am taking a class and I am having the urge to urinate. The little amount of urine is already formed, 400 ml, say for example 500 ml, and I want to go to the urinal. But because I am taking a class, I can inhibit it, so I am inhibiting it. This is the role of paracentral lobule. But when the paracentral lobule is damaged, whenever there is little amount of urine present in the bladder and the bladder muscles are stretched, reflex initiated, immediately the person will urinate irrespective of the situation. Because there is no cortical control, the paracentral lobule has been gone, so there will be urinary incontinence. जहाँ भर गया वहाँ urine करना है. Okay? So urinary incontinence will be there. 4th, there will be in the leg area which has been damaged. The person will not know how to utilize that leg area also. There will be a type of gait apraxia. To gait. because gait leg से ही होता है, paralysis हुआ तो how to utilize that leg, that is gone. Then there are some classical features related to frontal lobe disease. The person will have abulia. What is this abulia? That is a profound defect in initiating any activity. प्रोफाउंड लेजीनेस तो नहीं बोलेंगे, उस लेजीनेस का लिटरेचर टर्म को न्यूरोलॉजिकल टर्म में कन्वर्ट कर देते हैं. प्रोफाउंड डिफिकल्टी इन इनिशिएटिंग सम एक्टिविटी, वेरी स्लोली ही विल इनिशिएट एनी एक्टिविटी. दैट विल बी एबुलिया. दिस इज नोन एज एबुलिया. एंड इन द पैरालाइटिक साइड देयर विल बी पैराटोनिक रिजिडिटी. पैराटोनिक रिजिडिटी, paratonic rigidity, also known as Gegenhalten or Gegenhalten. Paratonic rigidity or what is this paratonic rigidity? When you are in the weak segment, in the weak motor or whatever, when you are testing the tone, when you start to manipulate the testing of tone, the patient will oppose the examiner. The person will oppose the force towards the examiner's movement. That is known as paratonic rigidity or Gegenhalten. Okay. Another important thing that occurs is reflexes. Reflexes, what I mean to say is pediatric reflexes. That is grasp reflex, sucking reflex, swallowing reflex. These are usually pediatric reflexes. When we age after infancy, the frontal lobe takes over. So these reflexes are needless. They are not required now as our frontal lobe matures. Those were required in the pediatric age group before infancy. For breast milk, sucking reflex, swallowing reflex, when you put a finger in the infant's hand, she will grasp it. All these reflexes are now not required, so frontal lobe inhibits the reflex. When there is a damage to the frontal lobe in those areas, there will be these reflexes will come up, they will manifest. So there will be contralateral grasp reflex, sucking reflex. These reflex will come over. Okay. Lastly, there can be an interesting phenomena on the paralyzed limb that is known as tactile aphasia. अगर पैरालाइज लिम्ब में अगर हमने कुछ हाथ में दिया और बोला कि ये क्या चीज है, आंख बंद करो, the person will replace the name to some other. The person is perceiving, but it is a kind of paraphrasia, aphasic paraphrasia. Say for example, if I give a key to the person and ask what is this, he will say it is a balloon. He will say it's a book. Remember, do not confuse tactile aphasia with stereognosis. Stereognosis is a parietal lobe disorder where eyes closed, you give something to the patient. The patient is not able to tell anything about it. But here, the person will take it in the hand and it will say it is a book, the key is a book, or key is a balloon. So this is one thing that can occur in frontal lobe disease. Usually without collateral circulation, a peripheral A2 segment obstruction. I will summarize. Contralateral hemiplegia, legs are more involved. Second, hemianesthesia, loss of touch, pain, temperature, position, vibration, sensations, all are lost on the legs, more than arm. Urinary incontinence, abulia, paratonic rigidity, Gegenhalten, tactile aphasia, all these things will be appearance of the pediatric reflexes, all will be the signs of if this is obstructed. Now, let us come to a second site. If there is obstruction of only artery of Hubner, that is the perforator, recurrent artery of Hubner. Usually this recurrent artery is the largest perforator of the anterocerebral artery. There are a lot of anatomical variants. Most commonly, some studies say that it most commonly arises just below the anterior communicating artery. In some studies, they say that usually it is shown to be arising from the A2 segment of the A2 part, that is the postcommunal part. But talking wherever, if it is present, sometimes recurrent artery of Hubner is not present at all. But we talk when the Hubner's artery is present. And in the diagram, what we have shown is the recurrent artery of Hubner are the perforators, and they are supplying these part. So, if there is a recurrent artery of Hubner occlusion, what will be the clinical features? Contralateral arm weakness, face weakness. So there will be a faciobrachial weakness. Faciobrachial weakness. Remember, these clinical presentation will be present in also middle cerebral territory stroke. But there are certain nuances. We will be talking about middle cerebral territory strokes. But remember, here in the anterocerebral artery, if there is a recurrent artery of Hubner stroke, there will be faciobrachial paralysis, spastic paralysis, spasticity, and faciobrachial weakness. And this is also supplying, if you see, these are the areas it is supplying. And most importantly, the caudate nucleus is also supplied by the recurrent artery of Hubner perforators. So this can be associated with hemichoria. Hemichoria. So if you are asked, what is this Hubner's artery stroke? You will say that Hubner's recurrent artery is the largest perforator of anterocerebral artery, and usually it presents with a spastic, sudden onset spastic weakness of that is a faciobrachial paralysis with or without association of hemichoria. Remember, leg is not paralyzed here. We are only talking of this segment. This is not involved. Only the perforators are involved. So this can be a rare presentation of recurrent artery of Hubner presentation. Okay. Next, if there is a total occlusion at the stem, total occlusion at the stem, total occlusion. Again, it is rare because in the circle of Willis or in the blood supply of the brain, we know that the anterior circulation strokes are rare because there is a profound communication. Anterior communicating artery from the other side, they can receive the brain from the enteral carotid artery, anterior communicating artery. Through the posterior communicating artery, whatever vascular artery can help. But if at all there is a lack of this collaterals development, whatever the situation, if at all theoretically presenting, if there is a rare situation, but if at all there is a stem involvement, then what will happen is it will be a mixed picture. Very logically speaking, you try to understand if this is here is gone, the patient is going to present with all the features of, that is the contralateral hemiplegia, contralateral sensory loss as I have described because of this stem occlusion, urinary incontinence, all the feature of distal which we described here, plus spastic faciobrachial. When the stroke will happen, very classically this kind of presentation is a tricky situation because of involvement of the leg area, because of the cortical involvement of the leg area. The initial presentation is very confusing. You will see a patient with hemiplegia, with spastic arm and face weakness, spastic arm plus face weakness, with a flaccid leg, weakness, plus bladder, urinary incontinence because of paracentral lobe involvement. So remember here, sometimes if you are not astute, you may confuse this, taking these pictures of a flaccid leg and urinary incontinence. This flaccid leg and urinary incontinence, you may confuse it with a caudaconus lesion. Because there is lower motor neuron signs, flaccidity, areflexia, urinary incontinence. Remember, it is not caudaconus. Maybe it is not caudaconus because examine the hand. There is spasticity in the hand. Pronator drift. Because I have told you, subtle clinical presentation. Arm may not be totally paralyzed. Early clinical signs of arm examination, you get a pronator drift, slight shifting of the fascias, slight dysarthria, and you will say that no, upper limb is also involved. There is a pronator drift, though power is still okay. So it is anterior. Secondly, there won't be any saddle anesthesia. Thirdly, after few days, this flaccid leg will become spastic because ultimately it is upper motor neuron. Then after some days, you will find that the reflexes has come, they are praised plantar extensor, and in caudaconus plantar is flexor or mute. So these signs you should. This is a very confusing situation. Interestingly, it should have been discussed. So I discussed if it will be a total stem, this is the clinical presentation, and if there is a peripheral stem occlusion, the clinical presentation I have already enumerated. Next. So another last rare situation. Consider in an unfortunate patient, one of the A1 segment is arthritic. It is not present functionally. It is a arthritic. It is not existing. It is just a thread losing like this. Arthritic. So what is here? This anterior cerebral artery, which is functional, through the anterior communicating artery is supplying to the other cortex also and supplying to the ipsilateral cortex also. इसी के भरोसे एक ही के भरोसे काम चल रहा है भैया, क्योंकि ये A1 segment तो है ही नहीं, it is arthritic. So now in this person, sometimes it is also known as occlusion of the unpaired branch of anterior cerebral artery. There is no pairing. There is the unpaired branch of anterior cerebral artery occluded. So there will be devastating consequence. Because everything उड़ गया, क्योंकि यही एक ही artery सब cortex supply कर रहा था, दोनों तरफ गया था ऊपर. So this kind of patient will present as stupor, urinary incontinence, most importantly, akinetic mutism. Akinetic and mute with paraplegia, sometimes quadriplegia also. So you are asked invariably in the examination, enumerate intracerebral causes of paraplegia or paraplegia due to higher center involvement, not spinal cord. So the first answer will be thrombosis or occlusion of the unpaired branch of anterior cerebral artery. दोनों लेग एरिया गया तो पैराप्लेजिया. समटाइम्स अगर आर्म भी वीकनेस होता है, जो हमने बोला है आर्म लेस देन लेग बट होता है ना, तो पैराप्लेजिया, क्वाड्रिप्लेजिया, कॉग्निटिव डिसफंक्शन बिकॉज द frontal lobe has the capacity to judgment, planning, cognitive dysfunction, abnormal behavior, urinary incontinence, paraplegia, quadriplegia, akinetic mute, ebulia, profound ebulia, akinetic and mute, bilateral, chala gaya if there is a anterocerebral unpaired branch of anterocerebral artery. So this is in gist. Anterocerebral artery territory stroke syndromes and distribution.